We now move ahead for the second lecture that features cardiac masses, how to differentiate. May I have the pleasure of inviting Professor I.B. Vijayalakshmi. She currently heads the Department of Pediatric Cardiology at Shri Yadava Institute for Cardiovascular Sciences and Research from Bangaluru, and she is credited for having started device closure in South India.
Respected chairpersons and dear delegates, I dedicate my today's lecture to my father, who taught me to be a sportsman and have a sportsman spirit, and all along, and he helped me to achieve the great heights, and he was a great person, a living saint. I dedicate it to him. Cardiac masses is defined as an abnormal structure within or immediately adjacent to the heart. The types of cardiac masses are tumors, which are primary or secondary, or we can have thrombus, vegetations, or even the normal anatomy looking like masses. Primary cardiac tumors are exceedingly rare. Prevalence is as low as 0.001 to 0.03% in the autopsy series. And thanks to the echocardiography, today we are making the diagnosis before the death. Fortunately, 75% of the cardiac tumors are characterized as benign neoplasms, and the cardiac myxoma account for almost 50% of these. The remaining 25% considered to be the malignant. The majority of these are sarcomas, and echocardiography is crucial in making the precise diagnosis. Among the benign tumors, we have myxoma, papillary fibroelastoma, rhabdomyoma, fibroma, teratoma, lipoma, lipomatous septal hypertrophy, and the Purkinje cell hematoma. Coming to the myxomas, the cardiac masses are usually solitary and develop in the atria. 75% of them originate at the left atrium, and 5 to 10% are familial associated with the Carney's complex. The classical triad of obstructive cardiac findings, embolic events, and constitutional systemic signs are characteristic. Echo, we can see the mobile pedunculated mass attached to the endocardial surface and typically arise from the fossa ovalis and have a very smooth surface and have a villous surface, and treatment sometimes it has to be prompt. Look at this lady. She had a mobile tumor which she was hardly 24 years, and then it's not playing. So it was coming like a tumor plop coming and going, and the whole of the mitral valve was getting obstructed. We advised for the emergency surgery. She said she would like to wait for the Monday till her husband came from Andamar, and Sunday night she had embolization and she was no more. And this is how these tumors can be really catastrophic at times. Papillary fibroelastoma, are 80% of them occur on the valve, especially on the aortic valve, like a C anemone, and these can embolize and causing the systemic embolization. They are attached to the surface of the aortic valve, not associated with aortic regurgitation, unlike the vegetations which damage the valve and cause the aortic regurgitation. So, rhabdomyomas are 45% to 63% of the papillary cardiac tumors, and they are seen in the pediatric age group, and we can make the diagnosis even in the intrauterine life with the fetal echocardiography. So this child, we had made the diagnosis even before the birth. And these are multiple, well circumscribed, white or gray-white intramural nodules, and they are multiple anywhere within the heart, most commonly involving the right and the left ventricles. And this was a 35 weeks fetus with multiple rhabdomyomas in a pregnant lady with the tuberous sclerosis, and all the 4 chambers had the rhabdomyomas. So they have a homogeneous echo-bright, finely speckled pattern, and in contrast to the intracardiac thrombi, myxomas and hemangiomas have a circumscribed echolucent areas as a result of hemorrhage formation inside them. So this is a teratoma, the typical appearance, And here 80% are benign. Components of all the 3 layers of hair, skin, muscle are seen in this, and that is how you make the fetal tumor and this thing. These are the fibromas, the second most common cardiac tumors, 95% present in children, and mesothelioma are extremely rare, and they are seen as in this patient. It was an 8-year-old child with the cyanosis, and then you can see that there is a sac in the inferior vena cava that indicates that there is an obstruction, and this obstruction can occur due to pericardial effusion, constrictive pericarditis, and rarely the tumors in the AV groove. So you can see here that there is a mesothelioma attached to the AV groove with the massive pericardial effusion, and on top of that the patient had non-compaction of both the left as well as the right ventricle, and that's how the child had presented with a massive congestive cardiac failure. So fibrolipomas are benign, well encapsulated fatty cells. Multiple locations are seen in this, as you can see here. This is a 40-year-old lady presented with the exertional dyspnea class 2, and the whole of the chamber is filled up and the mitral valve is being blocked by the huge mass. And again you can see here the spontaneous echo contrast in the inferior vena cava indicating that there is an obstruction, and you can literally see that the mass is compressing the whole of cardia, and the cardiac compression is so much the patient has presented with breathlessness and failure. And these extracardiac mass compressing the heart have to be differentiated from the masses which are intracardiac or in the intrapericardial. So extracardiac lung masses must be differentiated from the pericardial masses. Here you can see that this is a pericardial mass and the previous one was the extracardiac mass. So this is how they look, the intrapericardial tumors. And this is a 40-year-old male with a hydrated cyst. You can see that there are multiple daughter cysts, and after operation 250 daughter cysts were removed. So coming to the malignant tumors, we have sarcomas, angiosarcomas, rhabdomyosarcomas, and fibromyosarcomas. And this is a patient who had a metastatic papillary carcinoma secondary to the thyroid carcinoma in the intracardiac thing. So this is again a metastatic tumor in the right ventricle. This is a lung metastasis through the pulmonary vein, and that's how you can see that the mass is in the left atrium instead of on the right side. This was a 19-year-old male with a papillary cardiac sarcoma. He underwent surgery and it proved that it was a sarcoma. Coming to the cardiac thrombi, they form in the area wherever there is a stasis, and especially in the left atrium if there is a mitral stenosis and the dilated cardiomyopathy. And you can see that a number of thrombi you can see in the left atrium as well as the left ventricle, and this is the left ventricle and layered thrombus is there, and this is partially organized thrombus. So we can have post-MI multiple thrombi can be there, and this is a highly mobile thrombus and it can embolize at any time unless it organizes. So this is a 19-year-old boy, had a road accident and then he was operated upon, and then he came with the breathlessness, and we can see that there is a huge thrombus almost occupying the whole of the left ventricle, and young children without MI having a thrombus in the LV is extremely rare. So we can have thrombus in the diverticulum, the layered thrombus we can have on the prosthetic valve, we can have in the LA, we can, you name it, the thrombi can be present anywhere. And this is the not a tumor, it is a thrombus in the apical portion of the left ventricle, and that has to be distinguished because this mobile thrombus can embolize, causing the systemic embolization. So these are the tumors where you can see that literally occupying the whole of the mitral valve, and that's how they have to undergo surgery before it is too late. And you can see that it is mimicking like a mitral stenosis though the mitral valve is normal and the tumor is obstructing. So this is a football in the heart when a 42-year-old lady who had undergone CMV earlier and now has developed atrial fibrillation, and the ball valve thrombus is moving freely in the left atrium. and these have to be treated as an emergency, otherwise it can be very catastrophic for the patient. Now coming to the vegetations are usually on the mitral valve, tricuspid valve, all the 4 valves are depending on the shunt, they will be on the opposite side. In the PDA, there will be the pulmonary end. This is a 6-month-old child with weighing just 3 kilos and had a very catastrophic neonatal period. And look at that. When the patient came, there was a huge vegetation. We didn't know what it was. It was because of the umbilical vein and the arteries were tampered by the neonatologist for treating, and that's how it came with the huge vegetation attached to the tricuspid valve. And this is a 1-month-old baby, came with a fever, chest retractions, feeding difficulties. You can see that the whole vegetation is there, and this patient, before we could do anything, it embolized and the child died. This is a 5-year-old child with a history of fever for 1.5 months and had a very small ventricular septal defect, and you can see like the bunch of grapes, the vegetations are attached to the tricuspid valve, and that's the reason yesterday I was telling Dr. Mark that the AHA guidelines for the bacterial endocarditis prophylaxis is not adequate for the Indian scenario, because we get lots of children coming with the vegetation even after the IV fluids being given in the local hospital. You can see that there is a small ventricular septal defect, and that is literally closed by the vegetation, and this is how they come, and these vegetations can embolize. So we had 4 patients in a row. They went for the gastroenteritis, they went for pneumonia, they went for unconnected to the non-cardiac lesion, and then they ended up with the endocarditis on a normal valve. So this is the scenario. You can literally see that the vegetations are jumping and dancing inside the left ventricle. These are the multiple vegetations in the left ventricle, and you just can't predict when they are going to embolize elsewhere. And we had a patient with the vegetation even in the inferior vena cava. So you name it, once their IV fluids or IV injections or aseptic precautions are not taken, you can have vegetations all along the patient.
And sorry
this
for the
was a
interruption,
patient, yeah, I'm going to finish that. This is a patient of Garbude defect. Earlier we were not closing them, and this child, 2 years old, had a huge vegetation attached at the defect, and after that I started closing. Now we have closed 12 Garbude defects with the ADO2 so that they don't develop the vegetation and they don't die of that. So coming to the normal structures, we have, this is the comedian ridge, and that should not be mistaken as a mass in the left atrium. And this is the Chiari network, and that should not be mistaken as an abnormal structure. That is a normal structure. So the pathologist makes the perfect diagnosis, alas, a day too late. But an echocardiographer makes not so perfect diagnosis, but in time to save the precious life. Thank you very much for your time.
Thank you very much, Professor Vijayalakshmi.